of utilization of breast MRI. So to jump right in, the idea behind the whole field of breast imaging radiology is really to save lives and decrease the impact of breast cancer. We know that worldwide, the incidence of breast cancer is increasing. And in fact, in 2022, breast cancer surpassed all other cancers in being the most prevalent disease in 158 of 194 countries worldwide. So the most prevalent. There are a lot of reasons behind it, but the incidence, the point is increasing and affecting more and more women, as well as men in a minority of the cases worldwide. So really the main goals of decreasing the impact of breast cancer, first and foremost, especially in the face of this increasing incidence, is to decrease breast cancer-related mortality, so decrease the deaths from breast cancer, and also decrease the morbidity, so all of the side effects that are associated with more aggressive and toxic treatment. How do we do that? Well, detecting breast cancers at a smaller size, an earlier stage, leads to the reduction in breast cancer-related mortality and actually requires the utilization of less aggressive therapy. And in fact, there are studies, Dr. Tabar's research in particular is very impactful in this field, demonstrate that women who are diagnosed through screening at an earlier size and stage of breast cancer actually benefit more from the therapy that we provide them, in addition to requiring less aggressive therapy. You can imagine if the cancer is very small, you need smaller surgery, less likely to have spread everywhere, and so less likely is there a need for toxic chemotherapy. So this is the whole idea behind what I do as a specialist, what we do, those who deal with breast cancer diagnosis, screening, treatment, etc. So to that end, first and foremost, I know we're going to be talking about breast MR, but I think that we need to remember that to date, mammography, so a mammogram, is the only imaging modality that has been consistently found to decrease breast cancer-related mortality by as low as 40%. So it has been shown time and time again that if women start, average risk women, we'll talk a little bit about risk later, start screening mammography at age 40, continue screening mammography every year, as long as they are in good health. You know, if they are 75 and in very good health, they should continue screening because the risk of breast cancer doesn't go away. So for women who start screening at age 40, continuing annually, as long as they're in good health, the mortality reduction from screening mammography is as low as 40%, which is great. And in fact, a very powerful 2014 study of more than 7,000 women who were followed for over a decade demonstrated that 71% of breast cancer-related deaths are in those women who are not screened. Again, going back to the idea that screening allows us to detect breast cancer at an earlier size or a smaller size in an earlier stage, and allows us to detect cancer up to 4 to 5 years even before the cancer becomes clinically relevant, meaning before a woman is symptomatic with breast cancer, such as feeling a lump, having nipple discharge, and so on. So we're detecting an earlier version of that. And that early detection through screening results, again, in less invasive and less aggressive treatment. So that's to the benefit of the patient, and consistently has been shown, so this is a great study I highly recommend in Cancer in 2018 by Tabar, a greater survival benefit from treatment. So this is true, but although a mammogram is a good test, it is not a perfect test. In fact, it has a limited sensitivity for detection of breast cancer, in particular in those women who have increased breast density. And globally, about half of the women worldwide over the age of 40, so the younger you are, the denser your breasts anyways, but over age 40, about half of the world's population of women have dense breasts. And in fact, for Asian ethnicity women, it can actually be as high as 70% because it's a genetic predisposition. And it has been shown, this is a study from 2008 that actually looked to compare mammography, digital mammography, to screen film mammography, when we used to still hang them and look at them through light boxes. Ultimately, this DMIS study confirmed that digital mammography, the one that we see on our PAC screens, computer screens, is much better than film screen mammography, but still demonstrated that the sensitivity of even digital mammography is as low as 59% in younger women with dense breasts. So sensitivity is lower for basically half of the population. Also, even if we say that a mammogram is negative, doesn't mean that there's not a cancer lurking there, because our detection is not that great. It's a morphologic-based technique, meaning it's a technique that allows us only to see things and detect things, even with AI, if they form a mass, calcify, pull tissue together. Because of that, with screening mammography, there is almost 20%, but about a 17% interval cancer rate. And those are the cancers that are diagnosed between between screening mammograms. So if a woman had a negative screening mammogram, and before she comes back for the next year, there's a cancer she's presenting with symptomatically, that happens in about 17% of the time. And those cancers tend to have higher grade histology and worse prognosis. It is true that the addition of digital breast tomosynthesis that has been increasing in utilization does slightly increase the sensitivity of a mammogram, but still it is not a perfect test, in particular for about 0.5% of the patient population. And so I'm sure are all familiar. These are the full 4 grades of breast density. Breast density just refers to the proportion of fibroglandular tissue. So those are the ducts and the lobules that make milk if we're lactating, breastfeeding, compared to fat. And the more of the fibroglandular tissue we have, the denser the breast. And you can see this is the 4 categories that are defined by the American College of Radiology and the BI-RADS lexicon. This is a woman with very little fibroglandular tissue. So she is predominantly, her breasts are fatty. This is scattered. This is heterogeneously dense. There's much more of those fibroglandular elements. And this woman has, most of her breasts are made of fibroglandular tissue. So these 2 categories, which is half of the population worldwide, are dense. And again, even more in Asian ethnicity women. The issue with this is that not only is, as you can imagine, our sensitivity for mammography goes down, right? Because it's much easier to detect a cancer in this fatty breast than one that is hiding amid all of this fibroglandular tissue. What's more, the more fibroglandular tissue, the denser a woman is, the higher her risk of breast cancer development. She simply has more breast cells that can give rise to breast cancer. So sort of a 2-pronged problem. So this is really where breast MRI comes into play. So unlike mammography, which is an X-ray and a morphologic-based technique, just looking to see if something is, forming a mass, calcifying, causing a desmoplastic reaction, breast MRI is a vascular-based imaging technique. And it's based on the idea that a cancer anywhere in the body, but certainly in the breast, beyond a few millimeters, needs vascularity to grow. Otherwise, if there's no vascularity, and there's evidence increasingly of this, then those cells necrose, die out, and the immune system can clear it. So that there's evidence that this does happen. We just don't even detect these cancers. So cancer cells, cancer colonies, they either secrete VEGF factors to create vessels or recruit vessels from surrounding tissue, increasing vascularity. So because, and breast MRI is a technique where we inject contrast and into the vasculature and basically are looking for anything that actually enhances. Meaning taking up contrast. Anything that takes up contrast is vascular. So you can see here, this is an image of normal breast MRI. You can see the vessels, those are enhancing because there's contrast in it. The heart right here is enhancing, the liver, all the vasculature, and there's some normal breast tissue that's enhancing as well as the nipples. But because it is a vascular-based technique, two things are true. One, it is much more sensitive, as we're going to talk about in a minute, but also, therefore, it does not depend and is not limited by breast density, unlike a mammogram. So the sensitivity of an MRI does not depend on breast density. So now it is a tool that may be beneficial for that patient population. So as such, the current indications for breast MRI that are dictated by multiple society guidelines, including the NCCN, SBI, which is Society of Breast Imaging, American College of Radiology, and the European Society of Breast Imaging, are the following. Really, for high-risk screening, so for any patient, and we'll talk about why, who has more than 20% lifetime risk of developing breast cancer, they are considered to be high risk. For context, average risk is anybody below 15%. And in the United States, for instance, the average lifetime risk of breast cancer is about 13%. Globally, it's around 8% if you take all the population. So anybody who's 20% or higher is considered to be at a high risk. And for those individuals, high-risk screening MRI is recommended. Also, a new recommendation, and we'll talk about why, those women who have dense breasts on a mammogram, because the sensitivity is lower, because their risk of breast cancer is higher, also can benefit and are advised to get a breast MRI for additional screening. MRI, the other main sort of focus and use of breast MRI is to stage for newly diagnosed breast cancer. So those women we diagnose with breast cancer are recommended to undergo, and we'll again talk about why, breast MRI to look for local regional extent of disease. So the surgeon, the oncologist knows what they're dealing with, because often, as you will see, there's additional disease beyond the cancer that we detected. It is also the best technique we have so far to monitor the effect of neoadjuvant chemotherapy. So a woman who's getting chemotherapy upfront before surgery, to see how she's reacting. Serial breast MRIs are very helpful. It is also a good tool if there is an unknown breast malignancy primary. So for instance, somebody who came into the clinic with back pain, noted to have metastases in the spine. They did a biopsy. It was a adenocarcinoma breast primary, but a mammogram is negative. Then MRI is helpful because of its sensitivity. And also non-contrast MRI without contrast can be used to look at implant integrity for those who have silicone breast implants for augmentation, because it's much more sensitive than the other techniques. So these are the current recommendations. And what we're going to talk about is the evidence behind recommending it for screening, both high risk and dense breasts, and some of the evidence and challenges with recommending it for staging or newly diagnosed breast cancer evaluation, as those are really two of the main breast MRI roles. So let's jump right in, screening. So as breast MRI, the technique has been, was developed in the late 1990s, it was understood that breast MRI, because it is a vascular or functional-based technique, may have a greater sensitivity, again, because it is detecting all cancers that are clinically relevant have blood flow. So all it's detecting is where does the blood flow go? So it helps us pick up cancers. So multiple studies in the early 2000s were really looking at patients who are, are those who are at higher risk of breast cancer, and looking at the effect of breast MRI on breast cancer detection. So all of these studies consistently demonstrated that breast MRI had the highest sensitivity for breast cancer detection in women who have an increased lifetime risk of breast cancer, with a sensitivity up to 100%. And what's more, in these studies, about half of the cancers that were diagnosed with MRI, even going back, could not be seen under mammogram or ultrasound. So they were only detected under MR. So to really cement and evaluate this finding that MRI, it has a superior sensitivity in high-risk patients, were two main prospective studies, one in the United States called the Akron 6666, and one in Europe that were happening in parallel that I'll talk about. So these trials looked at women who have dense breasts and were at increased risk of breast cancer. And really, the original purpose of this studies were to look to see if adding an ultrasound to a mammogram is helpful or beneficial in this patient population. So they had women undergo a mammogram and an ultrasound, and they followed them for 3 years. Those women who had negative mammogram and ultrasound for 3 years, so no cancer detected, those women were then also offered a free, basically, would you like to also have an MRI? So what they saw in this patient population was this: the detection rate of a mammogram, and we talk about breast cancer detection rate in terms of cancers diagnosed per 1,000 women screened. So mammogram, and this is true today still, detects about 7 to 8 cancers per 1,000 women screened. They saw that adding an ultrasound to mammographic screening added about another 4 cancers to be detected per 1,000 women screened. As an aside, this has not been replicated in any other study. The reason ultrasound added so much more in terms of cancer detection rate was because 2 things. One, all of the ultrasounds were done by the doctors. I'm not sure, and we can talk about it later, if you do this as a physician, or do you have a dedicated technologist that does it? We have, just because we are so incredibly busy, we have dedicated breast sonographers, technologists that do the screening ultrasounds, and some also use automated ultrasounds. So they're a little bit more removed from sort of the diagnosis. And what's more, here, the doctors looked at the mammogram first, so they already had an idea, then went into the ultrasound. So I think there's a bias here. In general, ultrasound added to a mammogram adds about 2 or so additional cancers per 1,000 women screened. But the point is, here they saw, yes, adding an ultrasound to a mammogram is helpful. It does come at a huge false positive cost. But what was remarkable was, remember, all women who were not diagnosed with breast cancer, so none of these women, after 3 years of negative mammo and ultrasound offered an MRI, they saw that MRI detected 22 additional cancers per 1,000 women screened, or 22 cancers. And most of them were not additional, 22 overall, and most of them were not seen on a mammogram and ultrasound. So it had a 15 additional cancer detection rate of MRI added to mammography. The same study design was at the same time, basically, was done in Europe, the EVA trial, which looked at the same patient population, women who are at high risk of breast cancer, who have dense breast. They looked at a mammogram. Their detection is a little bit different in Europe. They don't screen every year. It was a little bit lower for a mammogram, 5 per 1,000. Adding an ultrasound adds about 2 cancers per 1,000 women screened. So this is true. And then when they looked at MRI, they saw that the additional cancer detection rate of MRI, these are women with negative mammogram and ultrasound, have additional 15 cancers detected by MRI that are not seen by a mammogram and ultrasound. What's more, in this study, when they added a mammogram and added an ultrasound again to the MRI, there was no statistically significant added benefit of addition of any imaging modality to MRI in terms of cancer detection rate, meaning MRI detects all the cancers that we can see, and twice as many cancers than a mammogram and an ultrasound. So this really, really cemented the recommendation now across all societies worldwide, European, as well as American societies, as well as a cancer network, that all women who are at a high risk of breast cancer should undergo MRI for high-risk screening. So this is one of my patients who is at high risk for breast cancer. She has a BRCA2 gene mutation. And she, in fact, she's 58 years old, came to us. She already had a breast cancer in the right breast a while ago. And actually, these images are flipped. I'm sorry. But so this is her mammogram. I'm just showing you the CC views. You can see that she's very dense. You can see there's some post-surgical changes here and this is the scar markers from her prior surgery. Nothing that I can see on a mammogram. she had a concurrent, about the same, a couple of days later, high-risk screening MRI. And this is her MRI. This is a post-contrast subtracted maximal intensity projection T1 weighted image. And what you can see, again, is just showing you anything that takes up contrast, anything that has vessels. So you can see the heart, you can see the vasculature. And what you can easily see here is that there is a mass in the outer right breast. You can also see that she's very dense here. So the mammogram is very much limited by breast density, but the MRI makes it very easy to see a little mass here. Doesn't take a radiologist. There's something in the outer breast. And here it is on multiple views. And you can see actually on the sagittal view, it's a little bit irregular. We tried to look for it with an ultrasound to see if we could find it. There was nothing on an ultrasound, even though we knew exactly where to look for it in the outer upper breast. And so because it was mammographically and sonographically occult, she underwent an MRI guided biopsy. You can see the obturator where the needle would be. It's right at that mass. This was sampled and came back as moderately differentiated invasive ductal carcinoma with lymphovascular invasion and DCIS. We put a clip at the end of the biopsy and have her post-biopsy mammogram, and you can see that even in retrospect, knowing there's a cancer there, this is where the clip is, where the invasive ductal carcinoma is, there is nothing on the mammogram that can be detected, even though we know exactly where the cancer is. So even in retrospect, this is mammographically occult. So based on all of these studies, again, annual breast MRI is recommended for high-risk women. And the recommendation is in addition to annual mammography in high-risk patients. So why, if an MRI is detecting all the cancers, and I just told you that all of the studies show that actually the addition of a mammogram to an MRI does not statistically significantly increase our cancer detection rate, why are these women also recommended to have a mammogram? Just to torture them? Like, why are we doing it? And the reason behind it is, going back to my very first point, is that although MRI's sensitivity is much higher than a mammogram, mammography is the only test to date that has been tied to a decrease in the mortality from breast cancer with annual screening. And that's because we have 50, 60 years of data that show longitudinal effects and benefit of mammography in decreasing mortality from breast cancer. We don't have that much information yet for breast MRI. It hasn't been around for long enough. And what's more, we can definitively actually design a study where we look at a mammogram compared to MRI, because we know that if a mammogram has a clinical benefit for patients, then we can't not give it to patients. It's unethical. So we can, so therefore, at the moment, MRI is recommended in addition to mammography in all of these high-risk patients. But we can start to begin to understand that MRI probably has the same, if not better, mortality reduction, benefit reduction. Because the reason mammogram is tied to a mortality reduction is because it helps us diagnose breast cancers when they're smaller and at an earlier stage. Well, all the studies demonstrate that MRI consistently demonstrates improved and earlier detection of breast cancer. And in fact, preferentially detects more aggressive cancers. So cancers that have that are more aggressive tend to have more vascularity. So actually picks up more clinically relevant breast cancer. And so you can start to begin to think that in the future, as we have more and more data, MRI probably will show that the same mortality benefit as a mammogram, if not more. And in fact, there was a very interesting study elegantly designed by my colleagues at Memorial Sloan Kettering Cancer Center in New York, which looked at women for about a decade, for 10 years. And they had women who were screened with mammography only, and those who were screened with a mammogram and MRI. And what they saw, regardless of detection, was that there were 5 breast cancer-related deaths in the group that was screened with mammography only, and no breast cancer-related deaths in a group that were screened also with MR. So it's beginning to suggest that probably once we have enough data, mammogram in this patient population will no longer be needed. Okay, so this is great. And in fact, this is one another example of sort of the power and the benefit of a high-risk screening MRI in this patient population. This is another patient of mine, 47 years old, who already had a history of breast cancer. In fact, it was extensive on the right side, and she underwent a mastectomy. So she came in for her screening mammogram on the left side. So this is her mammogram. She's dense, nothing on it. And we even have tomosynthesis. I'm not showing it to you just to save time. There was nothing on that mammogram. She had a concurrent within a few days screening breast MRI. And again, it does not take a radiologist to detect this. You can see, again, what is taking up cancer, multiple masses throughout the left breast compatible with a multicentric invasive ductal carcinoma on the left that is absolutely not seen on a mammogram. And this is her mastectomy breast. So again, underscores the power of this vascular functional breast technique in a high-risk patient population. But what about if breast MRI is so helpful and it detects breast cancers because it's a vascular functional breast technique? Is it only beneficial in patients who are at a high risk? So to answer that question, and overall, the answer is no. It seems to be beneficial for across all patient populations. The first study that to address and answer this question was by Dr. Christiane Kuhl out of Europe, who published a landmark prospective study, very similar to the Akron 6666 and the EVA trial, published in 2017. Again, looked at over 2,000 women who were not at high risk, but they followed them with a mammogram and an ultrasound and an MRI, and they followed them for over 2 years. And what they saw was that breast MRI had an additional cancer detection rate of about 15 cancers per 1,000 women screened, in addition to a mammogram and an ultrasound. And what was interesting is that she demonstrated that this was true regardless of breast density. So not just in women with dense breasts, but across breast density categories. So this is a chart, a graph from this study, and this is the citation from the study. I really recommend that you take a look. And in the gray bar, that's the distribution of patients in the study across the different breast density categories. So ACR-A is fatty breast, B scattered, C heterogeneously dense, and D extremely dense. And this color, plum, I guess, is the women in that breast density, mammographic breast density category that were diagnosed with breast cancer with MRI in that study. And you can see that the distribution of cancers is the same, really, as a distribution of breast densities, with cancers detected that are not seen on a mammogram, that are not seen on an ultrasound, even in fatty breast women. And so this is really important. So this was great. And so based on that, because certainly it seems to be helpful for all women, but MRI is a very expensive technique. It's a limited resource. It's not available everywhere. So we established that it's helpful for the high-risk population. We can see that it's helpful for all women across breast densities, but it's just not widely available. So based on this study, studies started to investigate breast MRI, in particular in average risk women, so not high risk, but with dense breasts, because we know that which is half of our population globally, that patient population has a slightly higher risk of breast cancer, even though they're not quite at high risk yet, and the sensitivity of a mammogram is a little bit lower. So what has been demonstrated consistently was that breast MRI is the best, the most superior additional screening technique in addition to a mammogram in women with dense breasts and average risk. This really was established with the DENSE trial, which demonstrated that women who have extremely dense breasts, so that category D, who just had a negative mammogram, and again, not high risk, MRI had the same cancer detection rate of about 16, 15 per 1,000 women. And what's more important is that actually, and again, getting at that mortality benefit, is that with screening with MRI, there was a significant decrease in interval cancer rates. So there were less cancers in between negative screens with MRI, and those are the cancers that tend to have bad prognosis. And then since then, a 2023 meta-analysis of more than 22 studies, over 250,000 patients of average risk and intermediate risk, but not high risk, in dense breast demonstrated that MRI is the best additional screening technique, even in this average risk population. So based on this, the recommendations, the guidelines have very recently changed. The European Society of Breast Imaging now recommends that all women who have extremely dense breasts, even if they're average risk, in particular, if they're just average risk, should have a breast MRI for additional screening in addition to a mammogram every 2 years after age 50. In the American College of Radiology, just this year, based on all of this data, now recommends that breast MRI should be done. Usually appropriate is the highest rating that ACR has. So this is the American guidelines recommending that women who have dense breasts, heterogeneously dense or extremely dense, have MRI as additional screening in addition to a mammogram. But this is great, but how do we accommodate such a large patient population to undergo breast MRI when it is expensive? It takes time. It's a lot longer than a mammogram, right? Usually an MRI takes about half an hour, and that's you can only have a certain number of patients through MRI compared to a mammogram, which only takes a couple of minutes, and it's not available everywhere. So how do you increase the access to this technique to a greater patient population? Well, that can be done. It has been shown through abbreviated breast MRI. And that really has been developed to accommodate this growing need for breast MRI and screening to increase access and reduce costs. And basically, no need to go through all the studies, but I will show you the punchline is that an abbreviated MRI, which is a shorter length of time to scan the breast with fewer sequences, less time points after contrast enhancement. But basically, abbreviated breast MRI can be as short as 3 minutes, as was done by Christian-Kuhl in 2014, which was really the very first example of abbreviated MRI, has equivalent, the same performance as a full protocol breast MRI. And same sensitivity, same specificity, so just as helpful. And so because of that, actually at Cornell, while Cornell at NewYork-Presbyterian, we have started to offer this year, actually last year, abbreviated breast MRI for patients who are not high risk, average risk, but have dense breasts with that abbreviated MRI protocol. And our protocol is about 5-6 minutes. So again, to summarize, breast MRI for screening is recommended and has been shown to be most sensitive and actually probably saves lives, as the evidence will show over the next couple of decades, in women who are at high risk, those who have a lifetime risk of breast cancer 20% or higher, anybody who has a genetic mutation with predisposition to developing breast cancer, such as BRCA1, 2, TP53, Lee-Frumanich, 2, ATM. There's more and more that we discover every year. And actually, the rule is that if they have if their first degree relative did not undergo genetic testing, they are treated as if they have a mutation and should undergo screening. Any woman who had personal history of chest radiation for non-Hodgkin lymphoma at age 10 to 30, because this is the prime time for breast cell development, and radiation can induce mutation. And this patient population has the same lifetime risk of breast cancer as BRCA1 and 2 patients. Any woman who has a breast cancer diagnosed prior to age 50 actually has a lifetime risk of having a second cancer of about 21%. And so in any woman who has a history of breast cancer and dense breast, so 2 risk factors, is at over 20% lifetime risk of breast cancer. So those this population, so anybody with a calculated 20% lifetime risk of breast cancer or greater, and these patient populations qualify and should undergo high-risk screening with breast MRI in addition to mammography. And increasingly, as I mentioned, also beneficial and recommended for those women who have dense breasts, even if they're not at high risk. So one of the controversies, one of the challenges and misunderstandings about breast MRI is, well, okay, it is very good. It is very sensitive. It helps us detect breast cancers, but at what cost? Does it have a very high false positive rate, which is what is always quoted as a negative aspect of MRI? Well, let's actually look at it. So if you, and I'm sure you know, anytime a person undergoes their very first examination, screening examination, certainly in breast imaging, the recall rate and the false positive rate is going to be the highest because it's the first time we see their breasts. We need to work up and evaluate certain things and certain findings before we establish a baseline. So for a screening mammogram, baseline, the very first mammogram that a woman undergoes, the recall rate is about 10 to 20%. For a screening MRI, the recall rate, the need for additional evaluation, either with a biopsy or follow-up, is about 8 to 15%. So actually lower than that of a baseline screening mammogram. And that of a screening ultrasound is as high as 17%. But what's important is that after that first MRI, after that first mammogram, the recall rate and the false positive rate decreases. Now we have an established baseline with screening mammogram recall rate being around 10%. So it drops from about 20 to 10%. But look at MRI, it drops significantly to as low as 2%. So yes, the rate is a little bit higher for that very first MRI, but not out of tune for a screening mammogram for the first time or a screening ultrasound. And what's more, it decreases significantly on the second round while maintaining the cancer detection rate. So if you look at this, the blue bars are the cancer detection rates per 1,000 women, and the orange are the incremental recall rate. So how much are we calling them back? And you can see that for ultrasound, the very first time you do it, cancer detection rate is kind of low, but we call them back a lot. Follow-up ultrasounds, second time, third year, fourth year, the cancer detection rate is still very low, but we're still calling them back much more, ending up having false positives than the benefit of the cancer detection rate. MRI, the cancer detection rate is very high. The false positive or recall rate is not that high. And then as you go to following incidence studies, follow up second, third, fourth year, you see that the cancer detection rate is still higher than our recall rate versus contrast enhanced mammography, tomosynthesis, or annual screening. So yes, there's a false positive rate, not out of tune with other baseline breast imaging. So for the first time, and it decreases sharply on follow-up years while maintaining cancer detection rate. So this is actually one of our patients that came to our program where we are offering abbreviated breast MRI for average risk women with dense breasts. She's 43, so she already had 3 years of mammograms that were all negative. This was her current mammogram in February of last year. You can see that she has dense breasts. The mammogram was definitely negative. And then she underwent a abbreviated screening MRI. And what you can see, yes, there's multiple similar masses in both breasts. That's just her normal background. We'll talk about that at the next seminar. But what, again, doesn't take a radiologist to detect, you can see right here, there's a mass that just stands out in the left breast. It's taken up blood flow, it's taken up contrast, and this did not have ultrasound correlate. So we looked in that location very, very carefully, could not find a sonographic correlate. Mammogram was negative. And so she underwent an MR guided biopsy, and this was high-grade ductal carcinoma in situ. 3 years of negative mammograms, even retrospectively, mammographically and sonographically occult. Significant added benefit to this patient to diagnose this early before it becomes invasive in the next couple of years, especially being high grade. Less invasive surgery, probably no need for any sort of chemotherapy, and the prognosis is going to be excellent. So so this is breast MRI for screening. I very briefly also want to talk about, in general, the role of breast MRI and the shift from age-based screening to risk-based screening. And just as an aside, so that you can understand also where the role of breast MRI can fit in if the resource is relatively limited, right? So most of the screening, breast cancer screening programs worldwide are based on age. At a certain age, a woman goes and starts their screening program. In the United States, it starts at 40. In Europe, it's variable and so on. But we have found out increasingly that their individual risk, and that works on a population basis, but on an individual basis, risk varies very widely between women, and age alone is an inadequate predictor. So this was a great study of more than almost 6 million patients that looked at different risk factors. The only risk factors they looked at was if the woman had breast cancer, if she had family history of breast cancer, or if she had dense breasts. And what they saw was that having just one of these risk factors increased the likelihood of having a cancer significantly. These are women who are 30 to 34 years old. Their cancer detection rate, their incidence of cancer is about 2 per 1,000 women. This is the same for women who are 35 to 39. If they had at least one risk factors, that is even higher than a woman who is age 40 and has no risk of breast cancer. And yet 40 is sort of our benchmark recommendation to start screening mammography, ignoring sort of all of these women. And what's more, the effect of cancer detection rate increases with age. So women who are age 50 or greater with at least one risk factor have almost 8 times as likely cancer detection rate compared to women who do not. So age alone is not an adequate predictor of developing breast cancer. So because of that, all of this guidelines now increasingly, so European Society of Breast Imaging, Society of Breast Imaging, and American College of Radiology and NCCN now recommend that really we should start shifting towards risk-based screening, where every woman should undergo assessment of her lifetime risk of breast cancer. And that's beyond the scope of this lecture, but I'm happy to answer questions about that. And if she's at 20% lifetime risk or greater, she should begin annual breast MRI in addition to mammography at about age 25 or 30, not age 40. So a really important role to start understanding more who these additional screening can benefit and identifying them earlier. So that is breast MRI for screening. Now we'll move on to the second part and the second role of breast MRI, and that is for extent of disease. So breast MRI has been demonstrated consistently to diagnose additional disease in 20% of patients who are newly diagnosed with breast cancer. So let's say they came to you with a palpable, or they were detected with a breast cancer in a screening mammogram, and then they undergo a breast MRI to look at local regional disease. 20% of these patients will have additional disease we did not know about and were not seen on a mammogram and ultrasound. 15% of the time, or 15% of them, are in the same breast and 5% in the other breast. This has been shown consistently, study after study after study. But yet a controversy, a debate still exists. Is it worthwhile for women to undergo consistently breast MRI before surgery and before treatment? And you would ask, why wouldn't it be if we are understanding and diagnosing additional disease in a fifth of the patient population? Well, those who oppose the use of breast MRI for extent of disease question these following issues. One, they say, well, yes, sure, you're diagnosing additional disease in 20% of the patient, but it makes no difference because the re-excision rate, where the surgeon has to go back and clean the margins of the lumpectomy of the surgery bed because they're positive on pathology, is probably the same based on the studies. And the recurrence rates are probably the same. And also, if we do that MRI, it seems to lead to unnecessary mastectomies where women go and have a mastectomy because of that MRI. And also, who cares about these additional cancers? They're going to be treated anyways with radiation and chemotherapy. Well, to answer those questions, here is the data. The re-excision rates that, meaning the need to go back after surgery, so a woman who has a lumpectomy, but the pathology, the surgical pathology shows positive margins, where the re-excision rates are the same in women who undergo breast MRI before the surgery and those who do not, are really based on very, very old data. One, that was before really the development of a 3 Tesla MRI. 3 Tesla MRI has a much better resolution and much more accurate evaluation of extent of disease. Also, this data comes from a time that did not have access. Breast MRI guided biopsies were not developed. And remember, I mentioned half of the time, there's cancers on MR that we don't see on a mammogram and ultrasound. So you see something on an MRI. How do you access it if you can't biopsy it? How do you tell the surgeon where to go? And so they really couldn't on that in those older studies. And the main study upon which they based the argument that, oh, the re-excision rates are the same was this old nationwide British study called the COMES trial, where they looked at women who had breast MRI before surgery and those who did not. And then they compared the re-excision rates, and they said that they were the same. And they were the same. They were about 19%. But if you look at the methods of the study, the surgeons never looked at the MRI, never took the recommendations of MRI of taking wider margins, et cetera, into account for their surgical planning. So you can't evaluate a technology if you don't use the data from that technology, right? So it's completely untrue, unbiased, unbased sort of criticism of breast MRI. And since then, there's a brand new MIPA study, which is a prospective study looking at women who have MRI before surgery. These are women with breast cancer before surgery and those who do not. And they look at their re-excision rates. Here, the surgeons use the information for breast MRI to guide and plan their surgery. And now what they demonstrated is that the re-excision rate drops from about 14% to 8% with the use of MRI, because the surgeons are able to take out all of the disease that is needed. What's more, they found that women, because this was not randomized, only women who wanted and their surgeons wanted MRI, underwent MRI. What they saw was that women who were already planning to undergo mastectomy were more likely to have a preoperative breast MRI ordered. So it's not that an MRI leads to mastectomies, it's that there's a selection bias here where those women who are, for whatever reason, the surgeons recommended, et cetera, who are already thinking about undergoing a mastectomy are more likely to have a preoperative MR. So you have to think about the clinical methodology. So then the next argument is the significance of additional disease, saying, oh, well, even if there's additional cancer, chemotherapy and radiation is going to take care of it. Well, not true. One issue behind is that increasingly we are moving from whole breast radiation to partial breast radiation, where we're just radiating the lumpectomy bed where the surgery was, because the outcomes are, the morbidity is much less. And so if there's additional cancer, and that happens in 15% of the time elsewhere in the breast, if it's away from the lumpectomy bed, it is not going to be treated by radiation. And in fact, there was a study in 2016 by Iaconi et al., which looked at breast cancer is only diagnosed additional disease that was diagnosed on extent of disease MRI in the same breast only. They didn't even look at the other breast, which is 5% of the time, that obviously would not be treated by radiation. And they saw that 25% of these additional cancers were more than a centimeter. About 23% were bigger than the original cancer. And about 2 of the 73 were actually upstaged the patient, so change their stage before treatment and surgery, which has clinical implications. So these, therefore, are significantly clinically relevant for treatment planning for the surgeons and oncologists. And now increasingly, we're not treating them with whole breast radiation. And this is actually one of my very first patients that I saw as an attending after graduating from fellowship. And this was a screening mammogram. It was her baseline, her very first one. I was very happy with myself because I saw these calcifications. I gave it a bar at 0. She came back for diagnostic mammogram, and these are magnification views. You can see some linear pleomorphic calcifications. Here was biopsied and was DCIS. She then underwent an extent disease MRI, and you can see here this clumped non-mass enhancement in the outer breast. This is her known DCIS, ductal carcinoma in situ, stage 0. I did my job as a doctor, as a breast radiologist. But as you move up, higher up in the breast, there's this irregular, heterogeneously enhancing mass that's abutting the pectoralis muscle in the upper inner quadrant that we did not see on a mammogram because it was so far medial and was not pulled out. This was invasive ductal carcinoma. If we didn't do that extent disease MRI, this is much more likely to have clinical significance and metastasize than the DCIS. So this is where extent disease MRI was really helpful. Additional patient that came from us from outside, she came with a left known biopsy-proven breast cancer, and the physician, the doctor, felt abnormal nodes in both axilla, both armpits. That has bad prognosis because now that's considered significantly metastatic. We did an extent disease MRI. We can see this known cancer in the left breast. There's a clip here from the biopsy, very abnormal node in the left axilla, and starting to see abnormal nodes in the right axilla. But what we didn't know about, and they didn't know on the outside clinic, because mammogram and ultrasound were negative, in the right breast, there's an additional, this area of clump non-mass enhancement, which was asynchronous, same time, but different biology, different receptor cancer. And in fact, this node was metastatic from this cancer, and this node was metastatic from this cancer. Completely different receptors, have to be treated differently in order to address it, and actually significantly change the staging of this patient. So in summary, breast MRI, just to remember, is the most sensitive breast cancer detection tool that we have. It is, if you have to prioritize, the main patient population to offer it to are those who are at a high risk of breast cancer, 20% or higher. But increasingly, it is beneficial if you can offer it, and you can do that potentially with an abbreviated, shorter protocol, so you can see more patients and it could be less costly, in particular for patients who have dense breasts. And breast MRI for extent disease is a very powerful tool that has clinical implications on treatment, planning, prognosis, and patient outcomes. And that's it. Thank you very much. Questions?
Dr. Katerina, thank you for your excellent presentation, and I'm sure everyone enjoyed it just as I did. And I actually, myself, I believe that breast MRI is very useful, but unfortunately, very underestimated and underused modality in our country due to higher costs and also lack of the equipment, lack of breast radiologists, and probably difficulties in interpretation of the studies. And your talk today helped us to clear up the confusions that we have. And now we can proceed to the question from the audience. Если у кого-то есть вопросы, вы можете включить микрофон и задать вопросы напрямую. Я проверяла в чате, пока письменных вопросов нет, и я думаю, что здесь присутствуют доктора, молодые доктора, резиденты, в том числе и доктора. We have both oncologists as well as radiologists as your audience today. Если воспользуйтесь своим шансом задать вопрос напрямую, потому что эта дискуссия будет очень полезна для радиологов всех наших стран.
Hello.
Hi there.
Hello, good evening, good morning. My name is Günel Musayeva. I am a medical oncologist from Azerbaijan, National Center of Oncology. At first, I would like to thank all organization committee, Azure Radiology Society for this opportunity, and Doctor for you for this excellent presentation. Maybe you have already mentioned that, but I want to ask again about that. Should all neoadjuvant patients undergo MRI before surgery? And my second question is the AI-based artificial intelligence based technology we're using in mammography, and what is the advances of AI-based technology in MRI? And I have also a third question, and my third question is tumor biology have impact in MRI detection? And should we take into consideration the tumor biology, not also the tumor, the risk factor, other risk factors, but also tumor biology? Thank you.
Okay. Yes, fantastic questions. Thank you so much. Pleasure meeting you. So let me go one by one. For neoadjuvant chemotherapy, it is very, very helpful, and studies demonstrate that what we see on preoperative MRI after neoadjuvant chemotherapy is linked to the prognosis ultimately and the final surgical pathology. So if the breast MRI, if after neoadjuvant chemotherapy, the enhancement is gone, then she is much more likely to have complete response to chemotherapy after final surgery. So it's very helpful to counsel your patients, and also helpful for the surgeon. They may take smaller margins. The surgery may be much less invasive and have less morbidity for the patient. And it is the most sensitive tool we have right now for evaluation of effect of chemotherapy. So, you're the oncologist. It's your, certainly your area. And in the very least, in counseling the patients of what to expect and sort of what their prognosis is. The second question was about AI and sort of the use of AI. Certainly, I definitely think it's the future. It's actually not the future, it's here now, across all imaging. It has been shown to show some benefit in mammography and even ultrasound, but it can't do more than the actual technique. A mammogram is still just an X-ray. That's all it is. It has no functional or vascular information. So increasingly, there is now more information and more studies that are developing AI for MRI. It's still in very early stages, but where it's beginning to be very helpful is that it may decrease the need for contrast or eliminate contrast and maintain the diagnostic accuracy. So that might be the future, using diffusion weighted imaging. So that's really where it's going. And then the final question was what? Remind me, number 3.
Tumor histobiology.
Yeah. So for extent of disease, definitely. So again, breast MRI detects additional cancers in 20% of patients with newly diagnosed breast cancer, across all risk categories and across all breast densities. But what we do know is, in particular for lobular carcinoma, ILC, mammogram and ultrasound don't do very well. They underestimate the extent of disease, and MRI is much better at doing it. So definitely, if you had to prioritize one patient population for extent of disease MRI before surgery and treatment, it would be lobular carcinoma. And there's lots of studies that support that. And I'm not sure if that's quite your question, but the appearance of different tumor biologies on MRI are going to be different. So lobular carcinoma, for instance, tends to enhance very, very late in a delayed fashion and look a certain way. And this is also a field where AI is being helpful, where based on certain features, it can predict the tumor receptors and biology going forward. Is it clinically helpful? I'm not sure, because we're going to do the biopsy anyways. So, here, I don't know where it adds, but there's definitely, it looks a little different depending on tumor biology, and AI can be helpful in that as well. Oh, here's some questions also in the chat. How does ACR type D composition and marked BP affect virus categorization? Great question. We're actually going to talk about that the next time that I am presenting. And so category D, so breast density has no impact on breast MRI because it's only looking at vascularity. BPE, which is background parenchymal enhancement, which is the enhancement of the normal tissue, does. And the higher the enhancement of the normal tissue, the lower the sensitivity of an MRI. What's important to know is that BPE and breast density are not tied together. A woman can have category D and no background parenchymal enhancement, or she can be category A and all of her tissue is enhancing. So they are not tied to each other, and both are different. We're going to talk about it more next time, because I'll have to show you examples. But so density, irrelevant for MRI, but BPE does, number one, affect our detection a little bit, and I'll talk about tricks of how to address it. And also, it's a prognostic factor, both for chemotherapy and also for risk of breast cancer. And then there's another question. Abbreviated MRI uses the same contrast agent in the same quantity as the usual. Yes. So it uses the same contrast, same dose per kilogram, but okay. So the preparation of the patient is going to be the same. The table time is going to be shorter because abbreviated breast MRI usually only has one pre-contrast and maybe 1 to 2, at most 3 post-contrast sequences and a T2 weighted image. That's it. No sagittals, no advanced imaging, etc. So therefore, you can really, and some abbreviated MRI protocols, there's no unified protocol. People are using different ones. Some use only one time point. So patient preparation before and patient after the nursing is going to be the same. Table time is going to be much shorter. It can be as short as 3 minutes. I will tell you, for us, so the exam is about 7 minutes. It takes us about 20, 30 minutes overall of the patient being there, because they have to come in, gown, IV, etc. Another question is, when is the best time for, okay, that is a fantastic question about when to perform MRI after surgery, routinely for all patients or only if the surgical margin is positive. So depends. If the surgical margins are positive, MRI can be very telling. And so normally right after surgery, remember the tissue is healing, it's going to have vascularity, it's going to have granulation tissue. You should see enhancement around the lumpectomy bed, but it should be smooth and uniform. If it's irregular and clumped anywhere, asymmetric, that is concern for cancer being left. So if a surgeon has a question, so they see negative margin, or I'm sorry, they see positive margins and they want you to help them, to guide them where to go, MRI can be helpful. You can do it, as soon as a few days later, whenever a patient can do it. As far as doing it routinely, I would treat it, remember, a woman who's diagnosed with breast cancer, certainly if she was diagnosed before age 50, now is in a high risk category. She should be having a breast MRI every year regardless. So then you can just wait and do an MRI, give her time to heal a little bit if there's no question of margins. And then MRI is now her routine part of her screening regimen, mammography and MRI. And then Next question, marked background parenchymal enhancement that has remained stable for 2 years with the regular appearing enhancing lesions that are also stable over time. Wonderful question. We're going to talk about that next time. In general, for breast imaging, if you see multiple similar appearing things bilaterally, it's a BI-RADS 2. If it's a mammogram, if it's an ultrasound, if it's an MRI. Even if they're irregular appearing and they're bilateral in multiple, remember, has to be 3 or more, right? 1 and 1 in each breast is not multiple, but at least 2 in one breast, 1 in the other, or more, and they all look the same, that's BPE. You can give it a 2. You don't even have to follow it. But you have to be very careful and look at anything that looks different. Then all the multiple the same. But we're definitely going to go through that next time. I also left my email, and I mean, hopefully I'll see all of you guys next time, which I think is in a couple of weeks. But if you have any questions, if I can be helpful at all in any way, certainly to the residents, to the young physicians, to anyone here, I'm always happy to answer any questions and to chat more about breast imaging.
Katerina, I also have a question for you.
Yeah.
And do you personally have an experience with contrast-enhanced mammography? And if so, can you tell us a little bit more about ups and downs of each modality compared to each other? Because here in Kazakhstan, probably we have bigger experience with contrast-enhanced mammography because, you know, the MRI for poor countries.
Yes, no, absolutely. I think it's a great question. And actually, my colleague, Kristen Coffey, is going to be speaking next week. She is a subject matter expert in contrast-enhanced mammography, as they started really the contrast-enhanced mammography at Memorial Sloan Kettering, which is where she trained. And now she's here with us at Cornell, and we started our program. So contrast-enhanced mammography is, again, a vascular-based technique. So it's functional, in addition to having the benefit of morphology. And there's not a lot of study. I mean, there are studies, but they're still not longitudinal. They're early on yet. But on all of these early studies, and again, because the idea is the same as an MRI, contrast-enhanced mammography works probably just as well as an MRI. So now in all the guidelines, it's recommended that anybody who cannot or does not want to undergo an MRI and needs to have an MRI should have a contrast-enhanced mammogram. You know, the benefits of contrast-enhanced mammography, as you mentioned, are cheaper, faster, much widely available. The downsides is that it may, you know, contrast reactions more common, allergies, you know, more common, but Dr. Coffey will definitely go through that and compare the two. So I would say absolutely, if you have contrast-enhanced mammography, and we're learning more and more about it, and its role is evolving for screening, for extent of disease, for diagnostic workup, it's a great test.
And also, do you perform breast MRI for all newly diagnosed breast cancers, or just for some subgroups? Because as far as I know, there is a lack of evidence that the better detection of the extent of the disease really affects the overall and disease-free survival and recurrence rate. And that's the main argument of our surgeons. Actually, they're opposed to contrast-enhanced modalities in general. They told us that there are no studies that show that it affects the endpoints of those studies are different.
Yeah, no, that's a great question. So we perform it. We also are dependent on our surgeons. So most of our surgeons, besides one, do it on all patients. One does not do it ever, no matter what. So, and again, because of these, and this is still the controversy, the debate and the challenge. So the studies are coming. We didn't have enough time yet to show it. But you can start understanding the biology. You can start inferring. We are being less invasive with our therapy, so we're not treating the whole breast anymore. What about those cancers in the other breast, the 5%? Who's treating those? No one. And sometimes they're different biology, need different chemotherapy. Knowing that MRI or any vascular-based technology will detect cancer that are more aggressive because it's vascular, you can start understanding the biology. The likelihood is that it is impacting mortality. There are some studies, and I'll share them maybe next time, that show that MRI, CM not yet, but actually decreases the interval cancer rate in those patients that undergo extent of disease MRI. An interval cancer rate has been used as a surrogate for mortality outcome. So, less aggressive interval cancers in this group. It just is going to require more data. So the MIPA study, that prospective study, a bigger analysis is to come.
Thank you. I'm gonna look into this study and do a small, very practical question about the clinical scenario when we see the enhancing lesion either on breast MRI or contrast enhanced mammography, but we cannot see this lesion on second look ultrasound. And in our countries, at least in our country, in Kazakhstan, we do not have MR or contrast enhanced mammography guided biopsy available here. So what back in in the past, what did you do? What would you recommend?
That's a great question. That is why the data is so bad from back then, because we saw it, but we couldn't really do anything about it. So maybe sometimes you can do biopsy by landmarks, if that's possible. You can kind of see where the tissue is, where it's sitting, and just go, blind under mammogram and ultrasound, if that's possible. Especially with contrast enhanced mammography, because you have the overlay of a mammogram, may be helpful, and just do a tomosynthesis guided biopsy, but it's not ideal. So, you will not have good patient outcomes until you can be precise. But try by landmarks. You can.
That's a problem that we're having now. Yeah, sometimes it happens.
Yeah, so the contrast enhanced mammography software shouldn't be very, MRI is, but is not a lot. In particular, I would talk to, I don't know if you have GE in Kazakhstan. They tend to have,
we are working on G machines. Yeah.
So it's not a huge added cost or maintenance. It's actually pretty minimal incremental, and it may be worth it, and much lower investment than a breast MR biopsy.
Yeah. Okay.
Thank you guys all so much. I have my email. Please reach out anytime. And I'm so looking forward to seeing some of you guys. Hopefully we'll come back for next time.
Thank you again. Thank you, everyone. See you again on the next webinar. Bye-bye.
Bye.